talk. We'll have a discussion later on. So moving on to the main important talk on surgical failures, think ahead. And Dr. Manish Singh, who is a fluent speaker on glaucoma, also an avid practitioner of glaucoma. Usually when I get a little confused, I talk to him regarding any diagnosis of the treatment protocols also. So he'll be talking on the surgical failures. Think ahead. Dr. Manish, please.
Thank you, sir, for having me part of this instruction course. So I'll be speaking on the surgical failures, think ahead. So in next 10 to 12 minutes, I'll basically be discussing about why a surgical failure happens, how we can manage a failing bleb, and what are the future options, medical and surgical, when you have a failing bleb. When we talk about surgical failure, we mainly mean trap failure, but now we know we also have other surgical options like the MIGS and the glaucoma shunt surgery. So I'll be a little bit touching about those surgical failures also. On a philosophical level, I'll tell you, blebs don't fail, they actually heal. It's a natural healing process of nature. When you create a stoma, when you create a flap, over the time tissue will heal. And studies have shown that even the best centers, that 50% of blebs, they heal by 5 years. So it's nothing unusual. What we aim in a glaucoma is a diffuse avascular bleb with pressure in early teens. But what we get, the reality is far from ideal. So what is important is that you have a meticulous follow-up of your trap patients. Try to detect these problems early so that you can manage them aggressively. The interesting thing about trap is that if you do the same technique in 3 different patients, you will have 3 different results. So it becomes very unpredictable at times, and it's not that reproducible like a cataract surgery. So very important in post-operative period, you evaluate the bleb, spend time with the patient, see the vascularity, what is the height of the bleb, what is the extent of the bleb, and very important, try to look for microcyst. If you compare these 2 bleb, this particular bleb has got multiple vessels. It's a formed bleb, but this is also a formed bleb with relatively avascular. So avascular bleb has a higher probability of surviving compared to a vascular bleb. This is a bleb which is failing. You can see multiple corkscrew vessels which have developed. Now they will cause fibrosis around the flap and the flow will be stopped. So it's a flat vascular bleb with no microcyst. In case you are not able to understand this cyst, you can use AIOC2024 or a UBM if available to see these small cystic area which basically indicate the functionality of the bleb. Now, why those bleb fail? The majority of the bleb fail because of the episcleral scarring, the natural healing which I was telling you. Apart from that, there can be other reasons like tight sutures, you can have a blocked stoma, or sometimes even a retained viscoelastic material may cause a failure of the bleb. So whenever you have a failed bleb, before starting any intervention, you should do a gonoscopy to see whether the stoma is patent or not. Because if the stoma is blocked, that blockage has to be removed. So this is a failing bleb. The pressure has started to increase. So how will you manage this? First, you increase your steroid to reduce the fibrosis. Give 5-FU injection. These are antifibrotic. We use mitomycin routinely in our trap patient. Even then, post-operatively, we do require 5-FU in some cases like these which are failing. Then you do digital massage to increase the flow through the scleral flap. And in case there are sutures left, you can go for a suture lysis or a release of releasable sutures. This is a case you can see the bleb is failing. You can see vascular with some blood also. You can see the releasable suture here. If you gently release the suture, you can just pull the end, and then little bit of massage, you will see the bleb will start to form. So these type of post-operative manipulations will definitely help you to prevent the failure. 5-FU injections are very useful, especially in cases of extensive fibrosis and congestion. We generally give 90° or 180° away from the bleb. Don't give it close to bleb, because if by chance it goes into the anterior chamber, it will cause severe reaction and can lead to endothelial decompensation. In this case, you can see we are giving 5-FU injection. Try to avoid the vessels to prevent the chances of subconjunctival hemorrhage. After injecting, using a cotton bud applicator, you can just gently spread it toward the bleb to reduce the bleb fibrosis. Tenon cyst or encapsulated blebs are also cause of failure. In this case, in early cases, if you can detect it, you can go for beta blockers and massage to prevent the failure. In later cases, you may require a bleb needling. So this example case, 8 weeks post-op, that is 2 months post-op, the pressures have started to increase. Now how we are going to manage? First, we'll start anti-glaucoma medication. Gonioscopy I've already discussed. You can consider needling to enhance the flow. Bleb revision, sometime we have tried, but somehow doesn't work very well with our hand. In case the bleb needling also doesn't work, the best option probably will be to go for a re-surgery, like a trabeculectomy again in a next site, or going for a shunt surgery. This is a video highlighting different types of bleb needling we can do in a trap patient and also in a shunt surgery. So what we have first done, this is a patient where you can see there is a localized bleb, it's congested. So using a 30 gauge needle or a 27 gauge needle, we enter at least 5 to 8 millimeter away from the flap. And what we are doing, using the sweeping movement, we are trying to cut the fibrous bands, the episcleral fibrosis over the surface of the scleral flap. You can see that slowly the bleb has started to form. If you are seeing by cutting this fibrous band, you are not able to raise the bleb, you can use the needle to enter into the anterior chamber by lifting the scleral flap. And then you can increase the flow. You can see the bleb has nicely been formed here. This is a bleb. And then if suppose the chamber becomes very shallow because of this, you can form the chamber with air. And we are giving a 5FU injection 180 degree away from the bleb. This is a case of tenon cyst using a 26 gauge needle. Again, what we are doing, we are trying to rupture the cyst wall so that the tenon cyst wall is ruptured and there is a direct communication of entry chamber with the subconjunctival space. So you are doing multiple punctures in the cyst wall. And once we have done that, you can see that bleb margin has become diffuse and it's a nicely well-formed bleb. This is a third case, a third scenario. Again, it's a trap done almost a year back. You can see a localized fibrous bleb. We are first trying to do needling superiorly. We are not able to lift the bleb. Sometime now what we can do, we can use a gonio lens. Nowadays, I think a lot of us have started doing MIGS. Using this lens, you can internally, using a spatula, try to lift the bleb. So you can see here, after doing internal, you can slightly lift the bleb, lift the scleral flap. And the last case I'd like to show about needling is a case of post-Ahmed valve hypertensive phase. The pressure has gone above 30 even on maximum medication. This case also you can do a needling, you can have multiple punctures. You can see immediately the bleb will start to form. Only thing, again later on the fibrosis may happen. So these cases have multiple puncture. Try to cut the cyst wall so that you can increase the flow of the bleb. In case your bleb needling has also not worked, even with medication you are not able to control intraocular pressure, then the option is to go for either a retrab or a shunt surgery. Diet cyclophotocoagulation is generally we reserve for cases with poor visual potential. Surgical failure is not always raised IOP. Sometimes surgical failure can also be low intraocular pressure resulting in hypotonic maculopathy. These cases initially we try steroids and cycloplegic. If it doesn't work, the vision is going down, autologous blood injection can be tried. It works very well in certain cases, especially in early cases where you still have some vascularity left. But then the results are mostly short-lived. This is a case where patient had hypertonic maculopathy. We injected blood. You can see we are injecting, trying to fill as much area of the bleb possible with the blood. Once you see the blood starting coming into the antechamber, then you stop injecting. You can see the blood is coming. This is a post-operative picture. You can see the improvement in the OCT. In certain cases, you can even try compression sutures. In extreme cases of hypotony, post-trab, with necrotic bleb, you may even have to go for a scleral patch graft. Just touching a bit about the shunt failure, hypertensive phase is very common with valved implant like the Ahmed glaucoma valve. These cases, we try using aqueous suppressants and bleb needling. Sometimes bleb revision can also be tried. In cases of tube which are close to the cornea, you can have late corneal decompensation. In this case, you may need to cut the tube or reposition the tube into the sulcus or the pars plana area. Plate and tube erosion need to be aggressively managed to prevent any infection. In case like these, you will require a scleral patch graft with a conjunctival patch graft. There is a case of failed Ahmed valve. You can see superiorly there is a valve here which had failed. Now we are trying inferiorly. When you're going inferiorly, you can go with the FP7 or you can go a smaller version, that is the FP8, because inferonasally the area is small. So in this case, you can try a FP8 version also. Another important thing is when you're suturing, don't suture it beyond 8 millimeter or beyond 10 millimeter, because FP7 valve, if you're suturing too posteriorly, the posterior edge of the valve will touch the optic nerve and can lead to traumatic optic neuropathy. You can see the post-operative period. This patient we are following up for 10 years now, and they are doing very well with these two Ahmed valves. This is a post-trap failure. You can see penetrating keratoplasty done. Patient had a vitrectomy done also. This case, because a PK has been done, we are going with a pars plana implantation of the valve. In this case, you can use a normal FP7 or a P8, or the pars plana variant of the Ahmed valve can also be used. Nowadays, what we are doing in cases of Ahmed valve failure, like this is a patient, young one-eyed patient where Ahmed valve has failed, we are going with a RD or a Ahmed clear path implantation, because once a valve implant has failed, you can try a null valve implant. I won't go into these surgical details. I think we all know how the steps of Ahmed valve surgery. This is a post-operative picture. You can see this has been, I think, almost 3-year follow-up we have. So superiorly, we had a Ahmed glaucoma valve, and infero-nasally, we had got the RD implant. Diet cyclophotocoagulation, cyclocryotherapy can be tried in cases of surgical failure where the visual potential is poor. I think Dr. Shilpi has already discussed them. Endoscopic cyclophotocoagulation has a better surgical rate, but the availability of the instrument is a problem. It's a very costly instrument. I think MIGS also is becoming popular now. MIGS, most of the studies are there for about 2 years. So if the pressure start to increasing, most cases you have to enhance the medication, or the best option is to go for a trabeculectomy. But there are reports where repeat eye stent or a GAT procedure has been done after a failed MIGS procedure. Macropulse laser also has been slightly discussed by Dr. Shilpi. This is a new technique, but then initially it was promoted for as an alternate to TRAB, but we found the results were not very predictable and short-lived, and there have been cases where vision has gone down also. But yes, it is definitely more safer compared to a diet cyclophotocoagulation. I'll just conclude saying glaucoma surgery is definitely far from being perfect. We have to be meticulous with all our patients, have a meticulous follow-up. If you recognize this complication early and manage aggressively, most of these patient eyes can be saved. And as a glaucoma surgeon, we need all types of weapon in the armamentarium, starting from trap to MIGS to shunts to needling. We should be aware of them so that we can use them correctly in the patient when it's required. Thank you so much, and my best wishes to all of you. Have a great time in Calcutta. Thank you.
Thank you, Manish, for a wonderful talk. One question.
Yes,
in
sir.
cases of trap failure, where we are going with a bleb revision kind of thing or needling kind of thing, should we add bang with, is there any study available with that?
We don't have any study like that. I think Dr. Satyan sir is there. Last time we had a meeting in Mumbai, and sir was sharing some experience where he has done I think eye stent with trap, sir, something like this. No, I think the question what Dr. Bibhuti sir is having in case of a failed trap, if you're doing a re-trap, whether it's justified to do a bang procedure or any MIGS procedure also.
Combined bang with that.
Combined. Probably, sir, there is no such studies like this till now. But sir was sharing his experience in a recent meeting in where he is trying a eye stent with a trap, a combination. So, sir, would you like to highlight something like this?
Yeah. So there is no any specific things that only you have to do it. You can do with the bang, you can do with the 360 GAT, you can do in the same site repeat trabeculectomy. There are various options are available for us, but only thing is it is a case-to-case basis.
There are no
Because
proper
we don't
studies
have a
as such.
nomogram kind of thing.
Yeah,
What
yeah.
is going to happen with both the procedure doing same time?
Yeah.
It's quite difficult, but I'm doing combined trap plus the bang together.
So what a kind of result IOP reduction you're getting in that? And what are the common complications which you get in that?
See,
Trap with bang.
There is no common complications as such. It is like when you do the bang, like in other MAGS procedures, how you get the hypema, it is same as that. There is no big difference. But we are, as beginners, we are just trying to make sure that any one of these procedure really works for the patient.
Okay.
So that is the ultimate goal.
Got your point.
And now what we are seeing is definitely the IOP drop is much better than doing an isolated trabeculectomy, or possibly isolated only a mixed procedure. But it is too early for me to just say everybody go and do that procedure.
Yeah. Thank you, Manish, for a wonderful talk.